Hello, a very warm welcome on site from the 25th AIDS conference, that is AIDS 2024, International AIDS Conference. And we are pleased to have with us today Po-Lin Chan, Regional Advisor, Hepatitis, HIV, STIs for WHO Southeast Asia region, and Dr. Gilada, Governing Council Member of International AIDS Society. Welcome to both of you, stalwarts in your respective fields. Po-Lin, can you please share your reflections if we are on track to end AIDS, TB, viral hepatitis, and STIs by 2030, along with achieving other SDGs in the Asia-Pacific region?
Thank you very much, Shobha. And this is a very loaded question because you just asked me about whether we will be ending AIDS, TB, HIV, sexually transmitted infections, and other SDGs in the Asia and Pacific region. And just to say that, no, what is clear from global reports, and even in the latest WHO Global Progress Report, that we have slid behind. Gains were reversed during the 2 or 3 years of the COVID-19 global pandemic. And most countries are not able to fully achieve the 2030 SDG targets. In fact, the UN Secretary General, in his report on the SDG Progress Report, said that the world is at risk because SDGs are not being achieved. So now today we stand, well, around 5 to 6 years from the SDGs of 2030. There's still time. But what is very clear for health in general, in the Asia Pacific and in CRO region, there's still time to try to build back and to build forwards better. We still can accelerate these 2 to 3 years. And the global report shows that between 2024 to 2026 is the few years that we can rebuild so that we can accelerate to achieve the targets of 2030 for HIV, for hepatitis and STIs, and also for TB as well. Thank you.
Po-Lin, we applaud the brilliance of initiatives like 95, 95, 95, and the community-led processes to make undetectable equal untransmittable. It has helped communicate the importance of finding all people with HIV, offering them best of treatments and care, and also stop further increase of infection. With 1.5 years left to deliver on these 95-95 goals, please share the progress made in the Asia-Pacific region and how we can accelerate it.
Thank you very much. Aside from the very few countries that are leading on the reduction of 95, 95, 95, Cambodia being one of them. Even Thailand has a commendable progress, but even then, today, with the current trajectory, they will not be able to reach the 2030 goals yet. But that means that they still have time to accelerate. But most of the other countries in the Southeast Asia region, India, Bangladesh, Nepal, Indonesia, Myanmar, and of course DPR Korea, Timor-Leste, they are still far from achieving the 2025 and the 2020 and the trajectory, the projected trajectory towards 2030 goals. But I'm an optimist.
Yes, right.
We have to be optimistic that countries will renew the efforts in getting towards the 2030 goals. Now, 2025 is just around the corner, so we still have time. We still have time to rebuild and to work forwards.
Thank you. Dr. Gilada, your thoughts on the challenges India is facing in achieving 95, 95, 95?
Thank you very much having me on this program, and this is a very important session. Number one, the challenge in India is that our focus on prevention is going down. It's not going down, it's gone down. The focus on intervention has gone down. Last 10 to 15 years, we are very, very weak in our prevention campaign. particularly if we talk about 2000 to 2010, when the campaigns were in high profile, those children which were born at that time, they never experienced that kind of campaign because they were very young. Now they are grown up, they are adolescents, they are around 25. So they have not gone through that very much high profile campaign for prevention, condom promotion, etc. And now they are vulnerable, they are getting infection. And rightly so, we are seeing new infections in young people. Secondly, our focus in India, which is drifted away from prevention and intervention to only care and support. Whenever we go to the next stages of care and support, viral load suppression, viral load monitoring, it doesn't mean that we should have stopped those previous interventions and gone to the next one. The next ones are in addition to previous one. And at two places where I find biggest weakness. Number one, that pre-exposure prophylaxis is not in the program. So it is a laughable situation where you allow people to get infected, and once they are infected, then you provide them free ART for lifetime, free viral load for lifetime, free monitoring for lifetime. But at the same time, you don't want to provide them a PrEP where they can prevent infection. Number two, that self HIV test is not available in program. And just now, Po-Lin said that how Cambodia and Thailand have gone ahead of us because of these two things, two interventions. So when we talk about first 95, I think among all the 395, first 95 is most crucial, because if you lag behind in first 95, you will always be behind in second and third 95, because the second and third will lead from the first one. So currently we in India are at 78, and many of the countries, they have leverage from India. They've gone ahead to 90 or 95, or some places in 97, 98. They are procuring medicines from India. They're providing medicine free of charge from their program, and they have gone ahead of India. So which were so bad countries earlier. Means I remember about 20, 30 years before, when we used to go to Africa, every third housewife was HIV positive. Every third pregnant woman was HIV positive. From that level to having the countries like Botswana, Swaziland, or Eswatini, they have achieved 95, 95, 95, one of the first in the globe. So I think Indian program has to be very proactive and must learn from those countries to whom we are taught. So it is nothing short of our human being nature that we should not learn from those to whom we are taught and whom we are helped. We should learn from them. And every time we talk to the national program, they say that no, PrEP will be coming, self HIV test will be coming. Self COVID testing was made available within days of the test available, and people could procure COVID test and do the test and self-isolate themselves. I don't know why we did not allow, or we do not still allow HIV self-test. That way it is available on platforms like Amazon. You can buy, but that is very expensive test. But if it is made available in the program free of charge, I think people will use it. And this is for those populations which are really marginalized. Either they are injection drug users, MSM community, bisexual community, LGBTQI community. Despite repeal of Section 377, there is still a lot of stigma and discrimination by which they are not going to come out openly. So when we talk about prevention campaign and first 95, whatever tools are available, every tool should be provided to everybody who want to access it.
May I just add on that?
Yes, please.
Thank you. So PrEP, or pre-exposure prophylaxis, as well as the whole area of self-testing. Of course, today we have HIV self-testing, which is all registered in most countries. We have also WHO just last week, or just recent these few days, have pre-qualified the first hepatitis C self-testing. And the hepatitis B self-testing is now in the pipeline. So this area of innovative technology that helps with putting choice to where people need to have choice is really important. And for most countries, it's not about piloting, it's bringing piloting to scale and coverage and making sure that these tests are available, PrEP is available, so that we can maximize what we can so that we can reduce infection and get to the achieving 2030. Thank you.
Thank you. You mentioned PrEP, both of you, and Thailand has been a champion in the region where community-led interventions have really helped in delivering PrEP to even the key populations. So, Po-Lin, you have mentioned what needs to be done more. It has to be taken to the people. So, how can we ensure PrEP and full range of combination prevention options are reaching everyone in the Asia-Pacific region? What about community-led interventions? And then Dr. Gilada, please on to that. What is happening in India regarding community-led interventions?
As we speak, there is a whole day session on community-led interventions, and there has been a lot of investment by different agencies to expand and also to put in and try to institutionalize community-led interventions. For now, many of the CLM approaches are still donor-based, but we need to move forward. We need to institutionalize as part of public health approaches, because this is what matters. And we have learned from many crises, the global HIV pandemic, the COVID-19 pandemic, how important engagement of communities and engagement of individuals are important to make sure that interventions are effective and are impactful. Thank you.
I would like to focus on two issues. Number one, as Po-Lin in her opening remarks said about hepatitis B also. Hepatitis B, hepatitis C, and syphilis tests are done at almost all the places, whether they're antenatal clinics, STI clinics, in hospital admissions. So as soon as the patient is getting admitted or for surgery, triple H test is done. But after triple H is done, what next? We do not even vaccinate those people which are hepatitis B negative. And the vaccines are damn cheap. They are available. If a program wants to purchase, for 100 rupees, you can get 3 doses of vaccine. And by providing 3 doses, they are immune for the entire life. So I think this is the cheapest thing which should have been done, easiest thing which should have been done. We are lagging behind. Currently, hepatitis B is growing with such a speed that I believe that hepatitis B and HPV, these are the two vaccine preventable infections. They are going to lead the show for next 10 to 20 years. The deaths due to hepatitis B and HPV will outnumber the deaths due to HIV, tuberculosis, and malaria together. Number one. Number two, on PrEP, we are making a system asking people to cheat. Now, if PEP, post-exposure prophylaxis, is available in the program, basic PEP is the same drug which is used for PrEP. So, tenofovir and emtricitabine. So, a person who wanting to get PrEP can go to a center and tell that I have been exposed yesterday and I want PEP. And he can get PEP and use that as a PrEP. But as a PrEP, it is not available. So, I think we cannot make a system whereby we are asking people to cheat and we are weakening our own program. So there has to be some answerability. And I think there is no better time than this time in India, because the health minister now is Mr. JP Nadda, who was health minister in 2017. And that was a turning point for India's HIV program. We had HIV/AIDS Act 2017 in 2017. We had test and treat started during 2017. And after that, we started viral load monitoring. So if that person is in the helm of the affair, I think he should immediately put question to NACO. What are you doing? Where are we in 95? And we are not enemies of our country. We would like to support our country in whatever best way we can. So let us have all the stakeholders together. WHO is sitting, Southeast Asia office is in Delhi. Get their expertise, get UNAIDS expertise, get private sector's expertise, and medicines are made in India. So medicines are made in India, provided all over the world to 150 countries, but not available in India. I think this is a dichotomy we must solve as early as possible.
Yes, Po-Lin, you want to add something? Yes, please.
I would like to add the whole area is not just about HIV.
Yes.
It's not just about STIs.
Yeah.
In fact, the Southeast Asia region is one of the region with highest burden of many things. We have 60 million STI cases of 4 of the curable cases: syphilis, gonorrhea, chlamydia, and trichomoniasis. That's in Southeast Asia region. Predominantly, actually, the burden is in India. In HIV, there are 3.9 million people with HIV in the Southeast Asia region. And in hepatitis, there's 70 million. Hepatitis B and C in the Southeast Asia region. And the main thing is in India, for example, hepatitis B and C testing and treatment is free. It's provided by government. But the problem is that not many people are going to get tested, even though the services are free. And in many states, they are now down to the district and at the PHC level too. In fact, WHO promotes and encourages countries to work towards triple elimination of mother-to-child transmission of HIV, syphilis, and viral hepatitis B, and contextually for C as well, especially for those partners who have injected or formerly injected. And this is important because in CRO, we have champion countries that have achieved the validation of triple elimination of mother-to-child transmission of HIV, syphilis, and now starting to work on hepatitis B. And these are Maldives, Sri Lanka, and Thailand. So we have experience in the region where countries know how to get there and to work towards, validation of elimination. Thank you.
Thank you, Po-Lin. And talking of hepatitis C, recently, the Community Network for Empowerment Manipur of India, they demonstrated same-day test and treat is possible for hepatitis C through community-led interventions. So you think those things can be replicated? If they could do it, then again, the involvement of community and trusting the community to go ahead with these interventions and the monitoring, will that help? Your thoughts on it?
See, hepatitis C is a good success in India. And fortunately, the program has taken care of providing free treatment for hepatitis C. Not only for India, hepatitis C, India is a role model for the entire world. The innovator company started the product at $84,000 for 84 days of treatment, $1,000 a day. And when they gave a voluntary license to Indian 11 companies and told them that you can sell this for $1,000 rather than $84,000. So the innovator company itself reduced the price by almost 99%. The 12th company, which did not get that voluntary license, said that we'll violate your patent and we'll make it available for $250 or $300. So today, India makes hepatitis C treatment available to the entire world at 0.3% of innovators' cost. And same thing has been taken into Indian program, particularly in the northeastern state where injection drug is very common, and in Punjab and Haryana where again it is very common. The problem is with hepatitis B, and we must make hepatitis B vaccination available at all the testing points. Particularly 3 or 4 most important testing points are antenatal clinic, because all the women are tested for hepatitis B. Blood bank, because every blood donor is tested for hepatitis B. STI clinics where hepatitis B is routinely done. And all the hospitals where inpatients are tested for hepatitis B. So we cannot be only mechanical in program that we are doing the testing, we're finding out who is positive, who is negative. But for negative, we are not advising anything. To give you example of hepatitis B, we have many number of VVIPs dying of hepatitis B related cancer, hepatitis B related cirrhosis. I don't want to name here, but there are n number of VVIPs. So even if we don't learn from this VIP syndrome, which is India is good at, that for any disease, if VIP suffers, then it is very important disease. And if VIP doesn't suffer, it is not important disease. From that also, we have not learned for hepatitis B. I think we should focus hepatitis B vaccination program. And if it is done fantastically, I don't think it is required more than a year to completely vaccinate the unvaccinated population. Fortunately, Government of India started hepatitis B vaccination program in expanded program of immunization from 2011. And some practitioners have been advising another 10 years before that. But those people who are born before 2000, they are not vaccinated against hepatitis B. and we need to focus that population.
Thank you, Dr. Saab. And Po-Lin, you rightly remarked it's not just about HIV. And that brings me to tuberculosis, because TB is still one of the major killers of people living with HIV. And according to the WHO Global TB report, 11,000 people in India, HIV positive people, died of tuberculosis. And what more can be done that to prevent TB among people living with HIV by diagnosing, finding TB early, putting them to care and treatment? And one of the activists recently remarked that persons living with HIV are dying of TB because of inaccessible diagnostics. So, what do you have to say on that?
Thank you very much. In the most recent report from WHO, TB and hepatitis is the top leading communicable disease death in the whole world, which is they are all both at the same rank of the second leading cause of death after COVID-19. COVID-19 is the first, TB and hepatitis is the second. More than 1.3 million people each die per year. I do think that TB is really important, and for most of the Southeast Asia region, the countries are high burden, and they need to continue accelerating coverage. But most importantly, because the TB program has had a lot of new things coming in. That means better diagnostics, including the TB LAM. There's shorter regimens that instead of doing 9 months, there's better MDR treatment regimens. But most important thing, TPT, TB preventive therapy, which is now down to, for people who live with HIV, 1 month. Instead of taking 9 months or 6 months or 3 months, this is the 1 month regimen. And this is now actually available and is now starting to be scaled up in many countries. But guidelines have to change, and they have to be adapted quite rapidly in order to maximize this kind of rapid evolution of the global guidelines. But yes, the most important thing to reduce death is really making sure that people get diagnosed earlier, and making sure that people who are in HIV get diagnosed, because sometimes they may be going to a facility, but they're just not diagnosed because the medical officer forgot to ask symptoms, or is asymptomatic, or forgot to ask whether households have symptoms, because sometimes it's not the PL-HIV that got infected, it's the household that got infected and infecting the PL-HIV. So these are things that in clinical practice, and to be pragmatic, is first, just get diagnosed. And for people who live with HIV, better treatment literacy. Understand that TB is a risk every day, at any time, even on ART. And if they are not on ART, then the risk is even greater. What do you say, Dr. Gilada?
Can I just ask one more question? So that, Po-Lin, and screening for TB in people living with HIV, is the first symptom verbal screening enough? Because lot of cases are asymptomatic in tuberculosis, and now we have handheld X-rays and tools which can be basically carried to the doors of the people, where you can screen for TB and then of course go for the diagnostic test and put them on TPT if need be. Yes, Tom.
I'm reminded of a TB screening program of 3 decades before, where in Mumbai and in many places, they used to have a TB van going around in the slums and doing mobile X-rays and diagnosing there. So I think we should adopt those strategies again if they work. Secondly, for every program, there are not very many shortcomings, only one or two shortcomings. But those shortcomings remain for decades. For example, I was on a latent TB committee of Government of India. We approved rifampicin INH prophylaxis 4 years before. Till today, it is not available. They said procurement is done. The irony is that there's only one company in the world which makes rifampicin INH prophylaxis. That company makes in Mumbai, in India, provides all over the world, but not available in India. We cannot use it unless and until it is licensed. Number two, the TB lab test, which is the most important test, non-invasive test. You just do an urine test. That is available only for research purpose. It is not available in market. I think we are totally head in sand approach, where on one hand we would like to eradicate tuberculosis, eliminate tuberculosis by 2025, ahead of 5 years of global goal. Probably that is now being extended. On the other hand, we don't want to use those tools which are so easy to be used. And number three, many people in HIV, they are dying of tuberculosis after starting ART. That means the test and treat strategy itself is a killer for many patients, because our doctors, as Po-Lin said, they are not tuned to look at tuberculosis. We are not doing a screening of X-ray and ultrasonography before starting the program, because most of the time tuberculosis is in abdomen. And we are not even looking at CD4 count before starting the program, because in test and treat CD4 is not important. And CD4 below 100 is an invitation for cryptococcal meningitis and many other infections in brain. We are not doing cryptococcal antigen test, which can be diagnosed when the CD4 count is below 100. I think we cannot be only mechanical. We cannot be only having a lip service. We cannot be having only a tubular vision. The test and treat means you forget about everything, and you, as soon as you test, start treatment. I have been saying for last 30 years that HIV treatment is not an emergency. There are many other emergencies to be solved before starting ART. Test and treat, yes, in ideal situation, you test and treat. But in at least 10% circumstances, you cannot start on the same day. And those 10% people we need to identify. We need to put them in a proper program. If TB is required for TB program. And secondly, as Po-Lin said, that rather than 6-month or 9-month course of TB prevention, the same thing can be done either for 1 month, that is daily for 1 month, or weekly dose of 12 weeks. I don't know the wisdom of people sitting in the committees thinking that a weekly dose of 12 weeks is very difficult to achieve rather than one daily dose of 1 month. We have been giving vitamin D3 every week for 8 weeks or every week for 12 weeks. And that's being given for last 10 years. Very successful program. So along with that, we can also give this. So rather than 30 doses, we can have 12 doses. So we can have our reach faster and easier.
Po-Lin, any sparks of good practice examples in some countries of Southeast Asia? Picture is dismal, but there are bright sparks around. Yes.
I think every country has its own path, and every country actually struggle with the same thing. In fact, when you talk about advanced HIV disease, otherwise it's actually colloquially known as AIDS. We still have AIDS.
Yes, yes.
We call it advanced HIV disease now, but it's actually AIDS. And people forget, or practitioners forget, that AIDS is still fairly common. In fact, when we do a survey around the Southeast Asia, 11 countries, of the 9 countries that gave us responses, most of them see AIDS or advanced HIV disease between 20 to 60% of their new cases. Half, more than half. That means that, patients are just not coming back early. They're not coming early, or they were lost and they were not re-engaged early enough. So they came late again. So when you're late, you tend to get all the opportunistic infections, TB, cryptococcus, and other areas, histoplasmosis, CMV, retinitis. So these things are still occurring right now. And how do we make it better? Advocacy. Again, more advocacy, awareness. We have to rebuild awareness, because people forget that HIV is still around as a global pandemic. And we need all the champions, and we need the younger generation of champions and clinicians and medical students, pharmacists, nurses, to actually know and be trained on HIV and how to manage people better. Thank you.
Dr. Gilada, would you like to add something to that?
No, I just want to add 2 things. That number one, the goals or targets are made not always to achieve them. They are to activize the machinery. And by activizing machinery means that we make people active, proactive, taking extra steps. And number two, the conferences like this is 2024. They are again to reflect upon us. Are we able to do better than other countries in the world? Are we able to do equal to the other countries in the world? And if we are not able to do, then I think we should learn from such experiences and try and do implementation as early as possible. I do not know how many people from the national program will be at this conference, but I think they should make always effort to see that they are also here so that they can also learn from here and carry out the program in a better way. There's a saying that all good things have to change for the better. We know that we are doing good work, but it doesn't mean that we should stop there. We should be able to do better than that. And I think India has capacity to do that, and we should be able to do that. Thank you.
In this age where basically we have any information at our tips, we have chatbots, we have AI, but at the end, it's still the face at the end of the table, one-on-one or one-on group to chat, just like what we are today.
Yes.
Because that human connection is still important. And it's that human connection that will help people do self-risk perception, but also to take action for themselves as well. But going forward, it's not about why now. We have the what, we have the tools. It's a whole gamut of menu of innovations coming in. But really, it's around really how to do it. And really conferences like this, and also exchanges at the national level, at subnational level, at district, at primary level. It's about exchanging experience so that we can, learn from each other and learn by doing. Thank you.
Thank you very much. And thank you for putting a face to the disease. Disease comes later. The person comes first. And that is what the theme of the conference also says, put people first. So it is put. Thank you, very well said. And thank you, Dr. Gilada. And thank you, Po-Lin Chan, for being with us today for this very, very